Good evening. You are watching Medicine Today, live medical show. I'm happy that you are with us today. I am Dr. Saak Aslanian. I am the executive producer and the host for Medicine Today. I'm happy to have with me today world famous, a very distinguished perinatologist, that means a specialist in maternal-fetal medicine, Dr. Gregory DeVore. Welcome, Dr. DeVore.
Thank you.
Dr. DeVore is born in USA. He got his medical degree at University of Utah College of Medicine. He did his residency in obstetrics and gynecology at Yale University, as well as in the same institution, he did his fellowship in maternal-fetal medicine. He is board certified in obstetrics and gynecology. He is a clinical professor, Department of Obstetrics and Gynecology at David Geffen School of Medicine, UCLA. He has had throughout the years many achievements and recognitions. I have with me 30 pages of all the details, but it's suffice to say that he has 128 peer reviews. He has written 30 chapters in textbooks and 11 peer reviews. He is married to Dorothy for over 40 years. He has 7 children, 14 grandchildren. He has offices in Tarzana, in Pasadena, and in Lancaster. And today's topic will be prenatal tests and diagnostic studies, meaning that what tests we do when somebody is pregnant for the mother and for the baby. Welcome again, Dr. DeVore. Okay, first off, before we start, tell me something about your field. What you do?
Our field is very interesting. Traditionally, patients go to their obstetrician and gynecologist. They think that's the specialist for their care. A number of years ago, in fact, over 30 years ago, it was decided that there needed to be a subspecialty of high-risk obstetrics called maternal-fetal medicine. So this was created. And now there are several thousand physicians throughout the United States and throughout the world who practice this specialty of high-risk obstetrics. Our job is simply to help the obstetrician to do his job or her job. We work as a partner, as a team.
Okay, let's presume that a lady comes to you, not to you, of course, to obstetrician. For a while, let's take, why don't you take the role of obstetrician and gynecologist as well as perinatologist together? Okay. Suppose a lady comes to you and says, doctor, I did pregnancy test, I'm pregnant. So what test you do first to confirm that she's pregnant or not?
Okay. There are several tests. The one that's used the most frequently by the obstetrician is what's called the beta-HCG, or the blood test. And that blood test is much more sensitive. It picks up earlier the pregnancy, and it gives also information that's very helpful to the physician to know how the pregnancy is doing. Contrast that with a test that you may buy at the drugstore, a urine test. That may tell the patient she's pregnant, but may not give a lot of information that the doctor needs, so the doctor often will order a blood test to help him or her to be more specific and actually be more, have more information to help the patient.
As I understand, urine pregnancy test can be false negative and false positive too, meaning what?
Well, okay, false negative and false positive. False positive means that the test says that the patient is pregnant, but in reality she's not. Or false negative test means that she's not pregnant, in reality she is. So the test can be sometimes confusing. It depends on how the patient or the woman, for example, uses the test, what test she buys at the drugstore. Whereas a blood test is very specific and very accurate because it's done by a laboratory under very strict conditions to be sure that they don't have these types of problems.
You mentioned blood test, quantitative beta-HCG. What's the significance of that? For example, if somebody comes to you and you think that she's 4 weeks pregnant from the day husband kissed her, made her pregnant, 4 weeks, okay? And what the significance of the numbers?
Okay. For example, let's assume that she's 4 weeks from her last menstrual period. That's what we use in obstetrics.
Yeah.
But it's really 2 weeks from the time she became pregnant or her conception date. So if a patient thinks that she's 4 weeks pregnant, but the blood test value comes back and it's much higher, then she could be actually further along in her pregnancy or have sometimes a specific type of condition that the doctor needs to know about because it could be serious. On the other hand, if the value, for example, is low and she thinks she's 8 weeks pregnant, then again, it helps the doctor determine, is she really that far along, or are there problems with the pregnancy that he needs to address?
Suppose God called you, Dr. DeVore, you're a nice man, and God calls you and says, Dr. DeVore, there are 100 Marys who, the day of ovulation, had sex, and they are pregnant. But Marys don't know that. They only know good or bad sex, but they are pregnant. How many of those will have a baby, live baby, out of the 100 that the day conception date?
Approximately 40%.
40%. How many women will have a normal baby or baby once they know they are pregnant? Not from conception, they know, they congratulate, that you are pregnant.
Yeah, once a woman knows that she's pregnant by a blood test or a urine test, approximately 85% to 80% will have a pregnancy that will be a pregnancy of a live-born child. But again, due to the first trimester, the very first weeks of pregnancy, those early pregnancies, a woman may not even know that she is pregnant because she may have heavy bleeding and actually lose the conception, not even know that she's pregnant.
What are the reasons of losing pregnancy? Is it some movement they did, wrong movement? Did they jump or something? What's the reason?
Very good question. Many times we are asked the question when we find that the pregnancy has a problem that the patient loses the pregnancy, especially in the first trimester. They often think, did I do something wrong? Did I cause this? Did my husband do something to hurt me? Or did I fall? Did I stumble? What's interesting is about 75 to 80% of the time, the explanation is that the baby's not developing properly. So Mother Nature, who helped design the program, so to speak, has a built-in process that if things are not being made well, she stops the process, and so the pregnancy does not continue. So it's not the patient's fault. It happens to be actually a built-in safety mechanism, and sometimes, many times, a blessing in disguise when the pregnancy stops because things are not going well.
So we can't say that it was a woman's problem. It's nothing where a woman did it and lost the pregnancy. Husband has also something to do in regards to genetic composition.
Yes, as we all know, the pregnancy is a combination of genetic material from the father and from the mother. They both contribute equally. And sometimes if things are not going well, then that results in an early miscarriage that the patient experiences.
Okay. We know she's pregnant now. You congratulate it. The beta HCG is normal. Everything is okay. You tell the patient that don't tell anybody for so many weeks, because how many weeks you say don't tell family, because if something happens they're going to start talking if they miscarry. What's the period? How many weeks usually?
If a patient goes from the time that she knows that she's pregnant with the early testing until the 12th week or the 12th week of the pregnancy, by and large about 15% of those pregnancies will be lost or have problems. Once you reach the 12th week, the chance of having a normal baby is extremely high. And so many times patients will simply wait till the 12th week and say, okay, things are fine, you check out okay, and then they'll tell their friends that they're pregnant. Because
the 12 weeks is because organs are formed already. That's the main reason.
Yes, and by the 12th week from the last menstrual period, or 10 weeks from conception, the house has been built. During that early time period, the house is being constructed. The rooms are being built, the doors are being put in, the windows are being put in, the baby's being made. And that's where the problem lies, when the making of the baby runs into difficulty. But once the house is made and you make it through the 12th week, then things are pretty much set in stone, and then the baby then continues to grow and develop.
Okay, so she comes, she's pregnant, we congratulate her, we do some blood tests initially. Amongst these tests we do is what we call CBC, complete blood count. What's the purpose of that?
The CBC has several components. One is how many red cells. Now, what's a red cell? A red cell carries oxygen. When we breathe, for example, the oxygen goes to these red cells that take it throughout our body. So that's very important for nourishing the developing baby. Also, there's some other parts of the CBC, other cells that we can look at that may tell us about infection or some other difficulties. And so it's a nice screening test that the obstetrician uses to get an idea of whether the patient is anemic. That's important because if she is, that may tell us about certain diseases or things that we can do to make the anemia better.
Yeah. It can also affect the growth of the baby if she's anemic. I suspect.
Yes, if the patient does have anemia, and there's most of the time it's because they're not eating properly, so they have an iron deficiency anemia. We can fix that. We can make it better, and in doing so, we can help that the mother become more healthy.
Hepatitis B surface antigen. That's one of the other tests.
Yeah, hepatitis B. There are several types of hepatitis, but hepatitis B is very. It's almost worldwide. It's prevalent in many Asian countries and Middle Eastern countries. The trouble with hepatitis B, and many people carry this, is that if a patient is infected with hepatitis B, the baby, not knowing that the mother's infected at the time of birth, can acquire the virus and then be infected and can have significant damage for the newborn. So we want to screen everybody for hepatitis B and treat the newborn with special medications once they're born if the mother has this disease.
Okay. What about, we do cultures, gonorrhea, chlamydia?
Yes. The cultures, there are a number of different cultures. Some tests, for example, it's a blood test for syphilis. That's not a culture, but syphilis is a disease acquired through sexual intercourse. We test for that. We test for gonorrhea in certain high-risk groups. Women who have been sexually active with multiple partners, for example, may become pregnant, or women who may work in environments where they have a higher chance to acquire the gonorrhea. We test for that. Chlamydia also, because chlamydia has been associated with premature delivery and other types of problems. And so we do screening tests to try and find those conditions that we can do something about and treat and prevent an adverse outcome or a poor outcome for the baby.
In the meantime, though, when you made a comment about multiple sexual partners, women may have one partner, but that partner may have multiple woman partners too.
Yes,
in that way.
It goes that way, and many times, unfortunately, it's that way. The man has many partners, but the woman has one, or thinks she only has one.
So that's why we do that test to almost everybody. Yes. And you made a comment about syphilis, VDR. What about the rubella, a blood test, as well as the HIV?
Rubella is a disease. It's a virus that years ago affected pregnant women and caused significant damage to the unborn child. Now with the rubella vaccination, in fact, we have what's called herd immunity, which simply means that the large part of the population has been given vaccinations for this, and so the disease is not as prevalent or not as common as it used to be. HIV, however, is just the opposite. HIV infection it's almost an epidemic throughout the world, and women can acquire HIV through sexual intercourse, through a partner that may be infected. And the trouble with HIV is that if the child is infected and nobody knows about that, it can be devastating for the child. And so again, we have some medications we can give to the child when it's born to help prevent that from occurring. And so we also have to treat the mother sometimes with HIV infection differently with pregnancy.
What about thyroid test and cystic fibrosis?
Thyroid test, there's some controversy about thyroid test. Some people feel that a woman can have subclinical hypothyroidism, that is to say that the thyroid gland is not functioning like it should and the thyroid hormone is lower than it should be. It's quote unquote subclinical, meaning that they don't have any manifestations, but it's really a low value. Some discussion has occurred about testing patients for that. It's not clear yet if that's really a real benefit. It's out right for the time being. It's kind of up in the air as to which way they should go. But many times a physician will draw a thyroid test to see if the patient does require thyroid medication.
So we do follow that, though, the thyroid thing. Because it's important development of the baby, especially hypothyroid or hyperthyroid.
If a woman has true hypothyroidism and it's clinical, that's significant because the baby can have difficulties from that. But the real question is if you have symptoms, then of course we test. If a mother says, gee, I'm cold all the time and you have the classic symptoms of hypothyroidism or hyper, where it's too much, then we will test those patients for those for sure.
Okay. What about cystic fibrosis, doctor?
Cystic fibrosis is a disease that affects the lungs of the child, and as we know that children with cystic fibrosis often don't live past their mid-20s or sometimes late 30s or early 30s. It's a disease that's genetic. It requires two defects, one in the father, one in the mother, to be manifest in the child. And it's common in Eastern European people from Eastern Europe and other countries. And so right now, it's a test that's being offered to all pregnant patients. to see if indeed they are a carrier for that disease. If they are, then they can do further testing to see whether or not the baby's affected or not.
Okay, soon we're going to have the pictures on the screen of ultrasound. If you can, I would appreciate that to put the first picture. So as Dr. DeVore discusses ultrasound in early pregnancy. Here's a picture, Dr. DeVore. How many weeks do you think this one is?
Probably about 7 to 8 weeks pregnant.
Okay. And can you tell us what's that ring over there on the right side?
Yes. In the center, which is black, that's the fluid the baby floats in. That little round circle looks like a little donut. That's called the yolk sac. And the yolk sac, early in the pregnancy, is designed to nourish the developing embryo. And on the left, that bright white looks like an egg. That is the placenta forming. And the center, that kind of shadowy gray little structure looks like maybe a little peanut. That's the little embryo developing.
Okay. Next picture. This is 9 weeks.
Okay, this is now at 9 weeks. What we see, you can, if I could point that out, but I can't, of course, the way we are. But you'll see that on the upper left, like a circle with black in it. That represents the head developing, the brain developing, and that white area just below it is the body. And those little tiny dots on the side represent the limbs as they're developing and being formed.
Okay, let's come to the studio again. Dr. DeVore, how early by ultrasound an obstetrician or a perinatologist can detect the sex of the baby, boy or a girl, because this is very important in some cultures and they like to know as soon as possible?
Well, it depends on several factors. We certainly have a pretty good idea by 12 weeks. Now,
when you say 12, let's make it clear. We're talking 12 weeks from the day they got pregnant or 12 weeks from her last period?
And when we talk in terms of dates, we always talk in terms from the last menstrual period. We don't really talk conceptual age.
So from now
12
on,
weeks from the last menstrual period or 10 weeks from conception.
Yeah.
By 12 weeks, we many times will see the beginning of what I call the rocket ship sign.
What is it?
The rocket ship sign.
Okay, go ahead.
The rocket ship sign is simply the penis sticking straight up. And so we can see that. Now, once in a while, the clitoris can also fool us. And we've had cases where I thought it was a boy, I saw the rocket, and it came back later on it was a girl. But I'd say probably 90% of the time we're correct when we see the rocket ship sign.
When you say we, let's take, you are Dr. DeVore, you are world famous, you have the most expensive instruments, plus you have the knowledge to detect, versus regular OB/GYN guy like me, who's not as expert as you are in your field, and we don't have as big machines as you do. So what do you expect guys like us, obstetricians in our office, how many weeks? Yours is 12 weeks. With our machines who are 35,000 versus 200,000 yours, when do you think it's reasonable?
Well, I would say that if you're in your office with your kind of machine, at 12 weeks, I'd probably flip a coin.
Okay.
So because I use very specialized equipment that's very high resolution that helps me to see things better. I think for the obstetrician gynecologist, by the 18th week, they should very clearly see a boy or girl.
We do see earlier than that for sure. We can say that. Yeah, 18 for sure.
18 for sure.
Yeah.
I think at 16 weeks you should start seeing structures clearly. Now it depends on several factors. Not every ultrasound picture is the same. Some women have more, we call it extra tissue, than others do. We say you have more tissue than somebody else, and that sometimes affects our ability to see clearly. If a patient is very thin, then we have a better choice, of course, a better chance. Now we also can do what's called an endovaginal exam. We have a probe that looks like a big cigar. We can place that inside the vagina and get a clearer picture up to about the 14th week.
Okay. Now, lady is pregnant. We confirmed beta-HCG is okay. And how early in pregnancy, because there's this conception that, doctor, don't do blood, let's do ultrasound. How early that ultrasound will detect there's a pregnancy, viable pregnancy in utero? How many weeks? We know blood can tell, but like 2 weeks after getting pregnant, would ultrasound show anything?
No.
Okay.
The earliest we can see a hint of a pregnancy is 5 weeks from the last menstrual period or 3 weeks from conception. We
Okay.
start to see the very beginning, like a little tiny dot inside that black circle.
But
that we
it
talked
doesn't
about.
say to you that's a good pregnancy or not.
No, no. It just
It
tells
doesn't
us that
say.
it's inside the uterus. That's all that it tells
Okay,
us.
that's all.
Yeah.
The blood test though might give us some idea that that pregnancy is good or not.
Yes.
Okay.
If I see the embryo developing, and you do a blood test, and then in 48 hours, for example, you do another blood test, and it's not increasing like it's supposed to,
Yeah.
that may tell us that the embryo is not developing like it's
How
supposed to.
early would you see fetal heart rate beating by ultrasound
It depends, of course, on excuse me, on the technique or the technology that you have, but
and the machine?
and the machine and how you do it. But by 7 to 8 weeks, the heartbeat is very obvious and easy to detect.
Okay. So again, I like to remind you that when Dr. DeVore says 7 to 8 weeks, we are considering that week from the first day of the period where she was not
Yeah.
pregnant for 2 weeks. And now, okay, let's say baby is okay now. She's coming now around 10 weeks, 10, 11 weeks. Now, here there are a lot of tests that we are advised to do. One of them is the blood test. I call it AFP test, screening test. And the other one, which will come to that, is that nuchal translucency test, and the other one also blood test to know.
Right.
Okay, let's talk about those, please.
Okay, in the state of California, it's mandated by law that every single pregnant patient should be offered a first trimester test for Down syndrome screening. Now, there are two choices. One is a blood test only, so the blood is drawn and it's sent to the state laboratory and nothing's done with it at that time. A second approach, which most patients prefer, is a blood test followed by an ultrasound between 11 weeks and 13 weeks and 6 days of the pregnancy. There's a time window that ultrasound has to be performed. The ultrasound is done for a very specific reason, to look and measure, to look at the size of the fetus, because it's a fetus by now, and to look at the skin behind the
Okay,
neck.
I'd like to stop that. Let's put the next picture, please, so as Dr. DeVore can discuss that. This is the one, Doctor.
Yes, okay. On the left, you have a picture of a fetus. It's a artistic rendition at the top, and the bottom is the ultrasound. On the right, you'll see that behind the neck, that it's a wider area, it's more white. That's called a nuchal translucency. And below that, on the gray image, is the ultrasound. If the nuchal translucency is increased in size, that tells us that there's an increased risk for chromosomal defects, such as Down syndrome, and also congenital heart disease.
So this is done between what week, Dr. DeVore?
11 weeks and 13 weeks
Okay.
and 6 days.
Okay, let's come back to the studio, please. Okay, now, so this is the other one, and then there's another blood test we do. Then we discuss all these things together. Another blood test we do between 15 and 18 weeks.
Yes, it's actually you can do it between 15 and 20 weeks.
Yeah.
It's a second blood test. It looks at some of the hormones the first trimester test looks at, but adds some others. And so what the state of California does, they can take the results from the first trimester ultrasound and blood test and give the patient a risk for Down syndrome and say your risk is 1 in 1,000, 1 in 10,000. And then they do the second trimester blood test to make the testing a little bit better. They incorporate the two from the first trimester and the second trimester. Then they come up with another risk for Down syndrome. If you do both of those tests, one followed by the other, that they will pick up about 80 to 85% of all the Downs fetuses that are in the population. They will miss 15%, but pick up 85%.
Okay, nuchal translucency test. First of all, does it mean that if it's abnormal, baby is definitely abnormal or not?
No.
No. If it's normal, we definitely say it's normal or not. Nuchal translucency. Okay.
No.
Now, there is another test now going on. I'm sure you know more than I do that they do it around 10 or 11 weeks where they check the chromosome. Would you mind saying a few words about that?
Yeah, there's a new test that has been in the marketplace for just about a year almost. In fact, California, the Medi-Cal just approved the test to be offered to patients with certain risk factors. What it is, very briefly, when people have a blood test, they think, well, you're just drawing my blood and doing the same thing. But in the blood, there's many millions of different parts in that blood of things floating around that we can test. And in the woman who's pregnant, there's DNA that comes from the placenta that is actually broken down every minute. That DNA represents all of the chromosomes that the fetus has. And through some very sophisticated testing, they can actually identify the fetus that has a high risk for Down syndrome. And they identify 99+% of the fetuses with Down syndrome with this blood test. It can be done as early as 10 weeks and can be done throughout the pregnancy. So it's a very high-performing screening test that I believe within a year or two, this will be the way that we will all be testing patients or screening patients for Down syndrome.
Okay. Early signs of Down's possible was, as you discussed, nuchal translucency. Now we discuss the blood one, which is much more guaranteed, right?
It has a better detection rate.
Okay.
And it has what's called a lower false positive rate, which means you'll tell fewer people, the test is abnormal and the baby is normal. So it's a better test all the way around.
It's all the way around.
Yes.
If it was your wife pregnant, let's say, and then would you, and you're financially, supposedly you are limited, but you have to do something. Would you go doing the blood test plus this test to see?
Well, let me qualify the test. It's important to understand.
Yeah.
The blood test right now is not available for every pregnant woman. Only for certain types of pregnancies. For example, women over 35 qualify for the test. Women who have an abnormal first trimester or second trimester screening test for Down syndrome by the state of California qualify for the test. A woman who has had a previous child with a chromosomal defect qualifies for the test. Or a woman who has an ultrasound finding that suggests the fetus is at risk for Down syndrome qualifies for the test. That means that approximately 85% of the population do not qualify for the test.
But you're talking about amniocentesis.
No, I'm talking about the
new
blood
10
test.
Weeks, 11,
the new blood test.
Really?
Yeah, it's not approved for everybody, just for those 4 groups that I mentioned. Now, it may in the future be approved for everybody, but the studies, not all the studies are in to say that it's going to have the same, be as effective as far as detecting Down syndrome in a lower risk population. Let me just share something with your audience they need to know. Down syndrome, the incidence of Down syndrome changes based upon the age of the mother. If a woman is 22, her risk for Down syndrome may be 1 in 1,200. Whereas if you're 45, the risk may be 1 in 50. So as the age of the mother increases, the risk for Down syndrome increases. And so that's why that certain group of women over 35 have a higher risk for Down syndrome than the younger patient does.
Okay, let's see the other pictures, please, if you don't mind. These are the chromosomes, doctor, if you don't mind saying a few words.
Yes, what we have here is we have it looks like a normal chromosome. See the numbers 1 through 22, then the X and Y in the bottom right. The 22 chromosomes, think of it that the chromosome, one of it comes from the father and one comes from the mother. So you always have 2 chromosomes in each of those numbers, like 2 chromosomes for number 1, 2 chromosomes for number 21, 2 for 22. Now with Down syndrome, what occurs is that there's an extra chromosome at the 21st, at number 21. So you have 3 chromosomes and not 2, and that extra chromosome creates the problem.
Okay, let's go ahead. Next one, please. This is trisomy 21.
Yes, this is an example. As you look at the picture, all the chromosomes have 2. Each of the pairs have 2, except for number 21 that has 3. And this creates the problem called trisomy, tri meaning 3, trisomy 21 that leads to the problem.
Means what? Down syndrome?
Yes, that's a Down syndrome.
Okay, let's see the picture. Picture of the. What's characteristic about this baby?
Well, Down syndrome, it's interesting. Down syndrome is the most common genetic defect that we have in the population. Down's children, of course, are handicapped. They have mental retardation. There's a wide spectrum of mental retardation for these children. They can be high functioning or not high functioning. The biggest problem is they often have those severe birth defects involving the heart or the brain or the kidneys and other defects that go along with how they look that really makes it difficult for them sometimes because they have a very serious heart defect. They have to have a heart surgery. If they have water on their brain, that becomes a problem. So they sometimes have other things that really make it difficult for them.
And the next one, I think, is not that common. That's trisomy 18, if I'm not mistaken.
Yes. Now that, unlike Down syndrome, it has an extra chromosome at number 21. Number 18 has an extra chromosome. Now this is what we call almost a lethal birth defect, meaning that children who have this condition when they're born, they often don't survive beyond a year. 99% of them will not be alive after 1 year just because of the number of birth defects they have that are very severe, that they just don't do well, they don't thrive.
Next.
And this is a child that may have a chromosomal defect. I can't tell specifically which one it may be. Sometimes, in fact, when a pediatrician looks at a child, they may say, the child looks a little bit different. It doesn't look quite like a normal child. What's going on? Then the doctor will order blood tests to look at the chromosomes to see if something's amiss.
Dear viewers, we're going to be back in a minute or two after a short break.
Բժիշկ Սահակ Արսլանյան ծնած է նոր Մարաշ Լիփանան։ Իր համասարանական ուսումը ստացած է University of Hawaii-ն, ուր վկայված է բսակավոր արվեստից վկայականով քիմիափանության մեջ բարձր քննադանքով, Bachelor of Arts in Chemistry with High Honors, Magna Cum Laude։ Ինքը ընդրված է անդամ Phi Beta Kappa Honor Society-ն, University of Hawaii-ն։ Բժիշկ Սահակ Արսլանյան իր բժշկական վկայականը ստացած է Northwestern University-ն, որ գտնվի Շիքագոյի մեջ։ Իր մասնակցությունը ծննդաբերությանց եւ կանանց հիվանդությանց Obstetrics and Gynecology ըրած է University of Michigan-ի մեջ, որ գտնվի Ann Arbor, Michigan։ Իր անձնական թարմանադունը ունի Glendale-ի մեջ եւ միաժամանակ գտասավանդ է UCLA-ի ծննդաբերությանց եւ կանանց հիվանդությանց բաժնին մեջ։ Բժիշկ Սահակ Արսլանյան հիվանդ կընդունի իր Glendale-ի թարմանադան մեջ միան երկուշաբթի, չորեքշաբթի եւ ուրբաթ օրերը։ Բժիշկ Սահակ Արսլանյան գլխավոր արդատրիչն է Executive Producer Medicine Today բժշկական հաղորդաշարին։
I've heard that in Europe, from maternal blood tests, they can recover, as you said, fetal test, and know whether the baby is a boy or a girl at early weeks, 6, 7 weeks gestation.
Yes.
Would you mind telling a few words? Because in my culture, that's very crucial. They want to know if there's a way. Okay.
In Europe, and some people have done this in the United States, they're using the same technique that we use to look for Down syndrome, to look at the boy or girl part of the DNA that's in the blood of the mother to determine the sex of the child.
There is, but we don't do that early yet, except 10 weeks, 11 weeks at that time.
Yes.
With other tests.
Yes.
Okay, can we go ahead, please? This is Dr. DeVore's name and his title and the website. In your website, what do you have where people, if they want to go to that website, what do they see? What do they know? What do they learn?
Well, what we've done, we've developed a website to educate the patient. We have movies on prenatal diagnosis, on how we detect heart defects. I have a whole section on 3D ultrasound. We have a section on amniocentesis. I have movies I've made that educates the patient on different tests. So it's really patient-friendly, and we have really thousands of visits, millions of visits. I've received email from all over the world, people telling me that it's one of the most informative websites for the pregnant patient for these kinds of things.
So it's a www.fetal.com.
Yes.
Okay. So we will continue our discussion. Let's discuss now other pictures that we have that Dr. DeVore has provided us, if you don't mind. Go ahead, Dr. DeVore.
Yeah, this is just another example. What I have, excuse me, it's from a talk that I gave. It's called The Journey, which I actually give a talk that I've given it to physicians and non-physicians, showing the evolution of life from the beginning to the end in the womb. This just is an example showing a little embryo as it's developing, as I mentioned earlier, with the yolk sac. That big circle to the left is the yolk sac that nourishes the embryo. It's very important in the early development to help that embryo grow and develop properly.
Next picture.
And this is a 3D picture, and it shows 3 little embryos. It's triplets.
3 little embryos.
Yeah.
What's the difference between 3D and 4D?
Well, 3D looks like this.
Okay.
4D is that picture, but live, so you actually see the heart beating or you see the fetus moving.
In that way.
In that
Okay.
way.
Go ahead. Next one, please.
And this is now a little bit older embryo. Actually, now it's becoming a fetus. A fetus means that things have developed almost, and you see the head at the top, and the brain development, and the little the tummy, and the legs starting to form, and the arm buds. So this is the beginning of the body features starting to take and
What's
develop.
the curved kind of line that we see over there?
That's the little sac the fetus floats in. That's the wall of the sac, and that little line is the membrane. And when we have twins, for example, that membrane, how that membrane looks, tells us whether the twins are identical or whether they're fraternal.
Okay, next picture.
And this is a more advanced pregnancy. You actually can see the little bodies of the little fetuses as they're developing in the first trimester. Again, we have twins in the upper left and triplets on the bottom right.
Let's come to the studio. Now, patients now, they want to have souvenir pictures, and they go and have these 3D pictures, XYZ places. They all look the same to me. There's no, you can't say this looks like the father, this looks like mother. They all look the same. What do you think about that? Have you noticed that?
Well, here's what I've noticed. If you, for example, look at the early 3D pictures, they look here. They have kind of a gold look to them. If you go to our website, you now will see pictures look like a real human because we have new ways now of displaying the 3D.
Really?
Shadows. I don't know if you can see this. This is...
No, we can't. They can't do that. Yeah, they can't do that. But if they go to their website, they'll be able to see it.
You'll see pictures that you will not believe. It looks like a photograph of a child, and it's really from inside the womb.
Okay, now, is it possible to detect anomalies or problems on a 3D ultrasound where otherwise we could not have seen that?
Sure. The 3D ultrasound, the way that we use 3D ultrasound is I try to use it to see things that I can't see clearly with the other modalities. And in our practice, I actually use a number of different ultrasound technologies to try and get as much information. There have been 3D pictures that have shown us things that we couldn't see otherwise, and other times the other shows us a better picture than the 3D. So we have to use, it's like putting the pieces of a puzzle together. We have different pieces that represent different kinds of ultrasound technologies to try and get as much information as we possibly can.
Now, let's have the other picture, please.
And now this is a more further along in the first trimester. And you can see now the limbs and the head and the legs and the body. It looks like a little photograph of a little person.
Yeah, but what's different between this and when they do ultrasound, you see fetus like this?
Well, if you ask most mothers
yes,
who look at this picture and look at the traditional ultrasound that you do in your office,
they will choose this one.
They recognize it. It looks like a human being. It doesn't look like just a blob of black and white and gray scattered on the screen.
Okay, next picture. Okay, now here, this is genetic ultrasound we call that we like to do between certain weeks. Why we do it and what's the benefit of that? If you don't mind.
Okay. What you see on the screen, I have arrows pointing to different parts of the body. Those represent the ultrasound images that we talked about a moment ago that are non-3D. And those represent specific areas that we look at for birth defects. Now, what is a genetic ultrasound? I mentioned earlier that the screening test that California employs for the patients in the first and second trimester find about 85% of the Down's fetuses. The genetic ultrasound that we developed, looking at the anatomy very carefully, looking for specific birth defects, our yield was about 98 to 99% when we used ultrasound on top of the blood test.
So these arrows, we're going to come to the studio soon. Just explain to that, it checks what? It's checking?
Yeah, the arrows are pointing to different parts of the anatomy. The upper left and right images represent abnormalities in the brain that we would see, for example, with Down syndrome. On the left,
or anything.
But this was focusing on Downs primarily.
Yeah.
But they can be birth defects of any organ system that we can.
Let's come to studio now. So at this time between 18 and 20 weeks, we like to do it, genetic ultrasound. The significance of that week is compared to if somebody, let's say, they do a genetic ultrasound, they found that the baby is not normal, and they don't want to have the baby.
Okay.
Let's say. So they have a choice at that time to terminate the pregnancy.
Yeah.
Okay.
In California, the law is, as we understand it,
Yeah.
that a patient has until 24 weeks of the pregnancy to decide to continue the pregnancy or not. When we do a genetic ultrasound, we have a window that we can see many structures, identify many problems. When we find a problem, it's interesting what patients do. Some patients, we can have pretty severe birth defects, and they will tell me, I'm continuing the pregnancy. I do not want to terminate the pregnancy. Other patients will choose not to terminate the pregnancy, or choose to terminate the pregnancy. And a third group of patients sometimes puts the baby up for adoption. So we have three avenues that people can go down.
Okay. Till this stage, Dr. DeVore, 20 weeks, the only thing now I really like you to discuss, the trauma, the worry, the crying after woman and the husband, if the blood test, the AFP test came abnormal,
Sure.
and one in 90, one in 240 or 110, would you mind saying a few words about that? Because they become traumatized when
Yes.
they see that.
What happens with the state program, it goes something like this. A phone call will come to the physician's office from the state, and the state will say, or the person representing the state will say, the patient has a risk for Down syndrome of 1 in 100 or 1 in 50. And so what is conveyed to the patient is your test was abnormal for Down syndrome, and the patient often feels or thinks, that means my baby has Down syndrome. And it's not true. What it really says is your test is screen positive, meaning that you need to have additional testing to be sure the baby's okay. And it depends on how you present it to the patient. If you call the patient on a Friday night and say, your test for Down syndrome came back positive, she's going to cry all week and think her baby has Down syndrome. Versus saying, you had a screening test, it showed that there may be an increased risk for Down syndrome, and we're going to offer you some testing to be sure things are okay. Because if you think about this, if I told you your risk for Down syndrome was 1 in 50, okay? That means 1 time out of 50 you'd have a Downs baby. If I sent you to Las Vegas and I said to you, put all your money on the table, you're going to win the jackpot 49 times out of 50, what are you going to do? You're going to say, here's my money. I want to gamble. It's 49 times out of 50 is great odds. But the way we spin it makes people go crazy for Down syndrome, but in reality we're still saying to them, 49 times out of 50 you're okay, but let's take and do a test to assure you that you have a normal baby.
Okay, yeah. So we see that quite often. Now we reach 24, 25. Here comes the next test, diabetes testing.
Okay.
We do tests to see whether woman is diabetic, and woman says, doctor, I don't have any diabetes in the family, my mother, my father, I've never had this, why are you doing this test on me?
Well, it's interesting. Diabetes the testing has changed recently, the concept. We know that women over 25 and women who are overweight have a higher risk for diabetes than if they were not. We also know if there's a family history, there's a higher risk for diabetes. And so because many women in America have been eating more McDonald's than they should, perhaps, they are overweight, and they have a higher chance for diabetes. That's really become an epidemic in this country. So many physicians are suggesting that when they present for prenatal care for the first time, that they draw what's called a hemoglobin A1C to see if they have pre-gestational diabetes. That means they were diabetic but didn't know about
pregnancy.
it
Okay.
before they were pregnant. And then they're also, at 28 weeks, they do what's called, there's two choices now, a 1-hour screening test where the mother goes in, drinks some sugar, has her blood drawn. If it's positive or abnormal, then they do a 3-hour glucose tolerance test to see if they have diabetes 3 or 4 weeks later. The American Diabetes Association has suggested that abandon the 1 hour and the 3-hour test, simply do a 2-hour test at one setting at that 28 weeks. And if you do a 2-hour glucose tolerance test, it's either positive or negative. If that's whatever it is, you're finished.
2 hours meaning you draw the blood fasting and 2 hours, or fasting
and 1 hour and 2 hours.
And 2 hours, rather than, okay.
Rather than doing the 1 hour, waiting for a week to get the results back,
okay.
coming back and having the 3-hour test.
And what are the numbers now? Do you know about 1 hour is what they like to see. This is 50 gram, 75 gram glucola or 50 grams glucola?
I happen to have it on my, I never memorize it, but I have an application that I made that's on the iPad store. Here's what it is. If you look at the 2-hour test, let's find it here.
I was not aware of this new thing. We still go with the old stuff that we do. I do fasting and 1 hour. Go ahead.
The 2-hour is done between 24 and 28 weeks.
Yes.
And the fasting, if it's greater than 92, 1 hour greater than 180, and 2 hour greater than 153, and it's a 75 gram oral
glucola.
fast.
Okay.
Yeah. So these are the numbers.
Okay.
And
so significance of a diabetes in pregnancy.
What is significant? What is the significance?
And why somebody would become diabetic while she was not diabetic before?
Okay, let's answer that question first.
Okay.
You weren't. Let's pretend for a moment you weren't diabetic before you got pregnant, and then all of a sudden you say, "Well, why does pregnancy create diabetes?" There are hormones in pregnancy that are unique to pregnancy that affect how the insulin is handled in the body, and so we call them anti-insulin hormones. They prevent the insulin from working efficiently. They're related to the pregnancy state. And so that puts a stress on the pancreas and the insulin is not as efficient. So they develop what's called gestational diabetes, meaning diabetes during pregnancy. Now, why is that important? The trouble is, there are several things. One, women who have gestational diabetics, they have a higher risk of having a very large baby. We call it macrosomia. Now, what's wrong with the big baby?
Let's take the other picture. Sorry, I think
Okay.
we have that picture so as it can be impressive. If you don't mind having the pictures of 2 babies. Okay, go ahead, Dr. DeVore.
Classic example. Let's assume on the left we have a normal baby.
It is normal, baby.
Okay, and on the right we have
Nice looking boy.
we have a football player from the NFL. This is called macrosomia. And so what happens? It's as though with the diabetes, there's a lot more sugar and protein and nutrients that get across that placenta because mother's not handling it well. It's like the baby goes to the ice cream store every day of its life and eats and eats and eats and eats. They become huge. Now you say, what's wrong with that?
Because in some cultures, Dr. DeVore, we have a baby like this. We say, my God, what a healthy baby.
I know.
What a nice looking baby.
Well, here's the problem with it. The problem is if you're the man and you have a child that weighs 12 pounds, you walk around thinking, that's my boy. But if you're a woman, you have to push that baby out the traditional way, it may have problems coming out. And what we worry about the most is that the baby's head, for example, will come out of the birth, but the shoulders will get stuck. And when they get stuck, that creates trauma, and you can break the clavicle, you can cause nerve damage, you can cause all kinds of problems. Secondly, babies of mothers who have diabetes like this can have heart problems because of the diabetes affecting the heart. And the most important is that if a child of a mother who has diabetes that's unrecognized, that baby when it's born can develop what's called hypoglycemia, which means the sugar drops too low, and that baby can have brain damage if it's unrecognized.
Yeah. Okay, let's come back. Actually, let's see, come back to studio if you don't mind. Now, once you make diagnosis diabetes, of course that kid will have problems too, most probably. What happens? Why sugar, suddenly the mother's sugar diabetes goes away? And what are the chances that woman in the future to have a adult onset diabetes?
The reasons the sugars drop is because when the pregnancy is finished, that placenta that makes the hormones disappear. And so the insulin is no longer being challenged. It works now like it's supposed to. We know that women who have gestational diabetes may have up to a 40% risk for developing diabetes later in life. We call it type 2 diabetes or diabetes adult onset. It happens when they're older.
Okay, let's have the other pictures, please, if you don't mind. The one with the needle, that's we go back when they do amniocentesis. Go ahead, Dr. DeVore.
Amniocentesis is a test in which a needle is placed in the uterus and fluid is withdrawn to analyze the chromosomes or the DNA of the fetus. Now, it's interesting, it has a very interesting historical history. Amniocentesis was the only test available to determine and to diagnose Down syndrome before the screening test we talked about earlier came about,
yes,
which helped us to identify the high-risk patient. With the advent of the new screening test, the incidence of, or the number of amnios being done has dropped as much as 50 to 80%. Now, the problem with that is that patients don't realize one thing. The screening tests that we talked about are screening tests. If I were to look at all the chromosomal defects an amniocentesis picks up, say that's 100%, for example, the screening test that we've talked about earlier in the program only find 75 to 80% of those chromosomal defects. They miss 20%. In addition to that, a study that we participated in several years ago was published by what's called the NICHD, the National Institutes of Health. We have another new way of looking at DNA that you couldn't see before, and we can find over 80 syndromes of DNA abnormalities you can't see on the regular chromosomes that include autism, a lot of very serious defects. And some people are advocating, should we go back and even offer universal amniocentesis to everybody to pick up all these other genetic defects that are even more serious than Down syndrome?
But it has its risks too, Dr. DeVore, right? Amniocentesis is not a benign procedure. As you see, needle is stuck over there, there's an ultrasound.
Yes.
You can get infection, you may have this and that.
Well, here's the good news. The good news is this. We used to think at one time that the amniocentesis had a risk of about 1 in 100, meaning if you did 100 amniocentesis, you lose the pregnancy once. A study was done, a large study. They looked at two groups of patients who had the same risk for Down syndrome. They did amnio in one group, and one group said, I don't want an amnio. And they followed them throughout the pregnancy, and they found that the risk for abnormal outcome was 1 in 1,600.
I see. Okay, let's come to the studio, please. Dr. DeVore, I really thank you for accepting my invitation to come over here and discuss these important issues. There are a few more things to discuss, but we don't have enough time. So I thank you for your time. You're a good man, in one word, okay? Thank you very much for viewing audience. We'll see you next month.